Hello, my name is Nikolai Yusupov, and in this video I'd like to show you how to insert three devices that are supraglottic: an LMA, a Combi Tube, and a King Tube. And I want to also show you some of the important criteria to look at utilizing the manufacturer's guidelines and some of the tips that you could utilize in the field. So first I'm going to start with LMA. LMA stands for Laryngeal mask airway. And this device is sized based on patient's weight. So this one is for a patient between 30 and 50 kilograms, and you're going to put less than 20 mLs of air into the cuff. You notice that I inflated the cuff. The reason why is that I want to show you how it sits. So here I have a cutout mannequin. This is your trachea and this is your esophagus, and this airway sits in the upper esophageal sphincter. This is where it's going to meet resistance. So when it sits properly, it will look like so. This here portion is where the oxygen will come through and it will go into the laryngeal inlet, which is this part here. So once more, once it's seated properly, this is how it's going to look. Now, this device will not protect from aspiration. So if the patient were to vomit, it may go into the trachea because, as you can see, it doesn't isolate like an endotracheal tube would. Now, how are you going to insert this device? So step number one, pick the appropriate size. And for this patient, we're going to say we already pre-oxygenated them, place them on the monitor and monitoring their vital signs, pulse oximeter, and end-tidal CO2. So the manufacturer recommends is to deflate the cuff fully while the mask is lying flat. So what I'm going to do is showing you here, I'm placing LMA down. Ideally, you want to use a surface of the packaging that it comes with. And you want to deflate the mask, and notice there's no ridges or obstructions that will give me resistance when I'm inserted. Then I already said that I'm going to put 20 mLs of air into this device. The way I'm going to hold this is like a pen. You notice I'm placing my index finger in between the cuff and the tube. So the junction of the cuff and the tube is where my index finger sits. And I'm going to insert it with this motion down up against the hard palate into the hypopharynx, and my upper esophageal sphincter is going to be the point where I should meet resistance, and that's where I'm going to stop. Another important thing is you need a water-soluble lubricant. Now, very important that you do not place it in here. The reason why is that you are going to placing it on the posterior surface. So placing it on the front first may occlude where the oxygen goes through, and two, patient may aspirate your lubricant, and you do not want it. So all you really need is you need to place a bolus amount in the back of the LMA. You don't have to work it around your tube. This will suffice. The next thing that I'm going to do is I'm going to hold the head in this position. You actually want to position your patient in a sniffing position or intubation position for this device. And I'm going to go ahead and slide this over the hard palate of the patient, and I'm doing a counter pressure up against this arm. So as I'm inserting, I'm putting pressure. Now you may hear clicking sounds of the upper jaw, and this mannequin is made for intubation, so when the handle rocks back, you hear the clicking sounds of the teeth. But if you hear it in this instance, that's okay, because I'm actually pressing it up against the hard palate to insert it properly. In addition, with this device, you're not going to see exaggerated chest rise on this mannequin, right? But for the patient, you will see chest rise utilizing this device. So lift the back of the occiput, lubricate the hard palate a little bit, and then as I'm inserting, I'm making sure it doesn't fold onto itself, and I'm actually forcing my finger up against the hard palate as I am going down up until I meet resistance, and I'm looking down in the airway, and I'm trying to see if there's any kink or it's folding onto itself. I did not see it happen, right? Once I have placed it like so, you notice I'm no longer holding the tube in place, and you don't need to do that because this is not an endotracheal tube. Endotracheal tube sits in the trachea, so you had to position the patient, use a laryngoscope, and go through a lot of procedures. So in the tracheal tube, you must hold in place. This device, you don't want to hold in place. And in addition, when I'm going to inflate it, I want the shape of my distal cuff to take normal curvature of the patient's mouth, and I wanted to kind of see the tube pop up. This is why I don't want to hold it. We said less than 20 mLs that I'm going to put in. Right, and you notice it now has sealed. In the OR, they would use a pressure cuff. They would actually place a pressure cuff device and see the centimeters of water pressure. You don't want to exceed 60 centimeters of water pressure. So amount of volume you place in is totally different from the pressure that's exerted against the soft tissues. So I put less than 20 per the manufacturer's instruction. I place my cuff pressure and it should read less than 60. Then I'm going to go ahead and connect my Untitled CO2 meter, and I'm going to go ahead and connect my bag valve mask device, and I'm going to slowly squeeze the bag. You notice I have chest rise on the patient. Yeah, it's not going to be exaggerated, but with this device, you're not going to have an exaggerated movement. So how far deep down you're going to insert it up until the upper esophageal sphincter, you will meet resistance, you're going to stop. Right? And we're going to verify both the objective data, which is Untitled CO2, and lung sounds, as our subjective data, and negative epigastric sounds. So this device is, again, I said, is a supraglottic airway, will not prevent aspiration of the gastric contents, right? So, and I also want to show you where the oxygen and ventilation actually comes through it. So I'm going to deflate my cuff, take this out. So I'm going to put my glove on it so that you can see where your oxygen is actually coming out. So it's coming out from these ridges that you see here. Right? The next device that I'm going to talk about is the Combi Tube. Now the Combi Tube, I've seen students have a lot of issue with. The reason why is that you have now two tubes, and there's often confusion which is which. Right? So let's go through all the tubes first. So first of all, we have this tube marked number 1. And this, when you ventilate through this tube, the oxygen and the air is coming out through these holes or these fenestrations. It does not come out from the distal end. When you ventilate through this tube, it will come out from the distal end. And I'm just going to show you this so that you can see. So in the initial part, number 1, the air is coming out through these holes. It will not come out through the distal opening. Nothing. The moment I switch to tube number 2, there's nothing that's coming out through here, through these openings, through these fenestrations. But the moment I put my glove on the distal end, you notice, right, how it's inflating. So what's the purpose of this? The purpose of this is as follows. This device will sit 90% of the time in the esophagus, right? And the distal balloon will occlude the esophagus, and the proximal balloon will occlude the oral pharynx. And the oxygen will come in through these inlets here. Now, what's important to note is that sometimes inadvertently, this tube may go into your trachea. So if you do not get chest rise ventilating through tube number 1, and there's no lung sounds, you're going to go to tube number 2 because perhaps you inadvertently placed it into the trachea. But 90% of the time, it goes into the esophageal space. Now, you have 2 pilot balloons, and they note how much volume of air you're going to place in them. So tube number 1 has 100 ml of air. This tube is for an adult, usually greater than 6 feet in height. So it's height-based. And the other balloon will say 15 mLs. So that's the amount of air you're going to put in. And these 2 demarcations here is where your central incisors of the upper jaw will be. So upper teeth in between these 2 marks. If the patient has no teeth, you're going to use the soft tissue to mark where the insertion is. How are we going to place this device? So first, I'm going to go ahead and deflate my cuffs. And this device is used when you cannot intubate the patient and you cannot ventilate the patient with a BVM device. Oftentimes, paramedics use it as a rescue airway where they couldn't intubate, and it's used in cardiac arrest here as the definitive airway because sometimes you may not be able to intubate, so you will use in cardiac arrest situation to provide advanced airway in place. So let me deflate the cuffs and show you how it looks. Now, if a little tip I'll give you: if the patient is getting active CPR and BLS has already pumped a lot of air into the stomach, what may happen is, as you saw from tube number 2, it comes directly from this inlet, right, to this. And if you place this in and they're doing compressions, you may get sprayed with all their gastric contents. That's why the manufacturer places this adapter. This is essentially called aspiration arm. And what you want to do is, upon placement, if active CPR is going on, you want to close off tube number 2 so that you do not get sprayed. And you want to point this away from you, right? So if the gastric contents do come up, you're not going to get splashed in the face. Again, only for if active CPR is ongoing. You're also going to need to lubricate this tube. Do not lubricate the front end of it because you're going to close the fenestration, the openings. So you really just lubricate the tip of this, right, and the back, so to facilitate the insertion. How will you place the patient? So you'll place the patient in a neutral position for this. You don't have to elevate the head to do it. I see a lot of times students connect syringes so they're dangling down. I don't advocate doing this because it will be in your way when you're placing this. You see how cumbersome this becomes? So I don't connect my syringes. All I do is I just have it ready at 100 ml, at 15 ml. You could use one syringe if you so choose, right? And then what I'm going to do is I'm going to perform a jaw lift. Unlike a jaw thrust, so jaw thrust is you use both hands to elevate the mandible up. A jaw lift is essentially use your thumb to find the tongue and you're lifting the jaw upward. Lifting it like so will facilitate insertion of your Combi tube. So I'll hold my Combi tube in this hand, and you never want to jam it down. So lubricate, right? Jaw lift, come from the side, and you're going to insert it down and until the upper incisors are in between these 2 marks. Now that I'm satisfied, again, I'm not going to hold this in place. This is not an endotracheal tube. Ideally it goes into esophagus. And 2, when I inflate my cuffs, I want it to take normal curvature of the airway. So I'm going to first inflate the 100 ml balloon, which is noted here, with 100 mLs of air. And you notice how it took the natural curvature of the patient, right? Or in this instance, the mannequin. Here I'm going to put 15. I have this in place if the CPR was ongoing. If the CPR wasn't ongoing, you don't have to have this diverter in place. Then I'm going to go ahead and place my Untitled CO2. And I'm going to verify, right, with the balloon that reads number 1. So I have goose chest rise, right? I verify my Untitled CO2 and I auscultate my lung sounds for subjective data, right? There's no gastric insufflation. Do I have to check balloon number 2? No, I don't, because I know I have a placed in where? I have it placed in the esophagus. And if you see, if I ventilate this balloon here, the pouch of the stomach will start to inflate. Right? In addition, what can you use this second port for, right? So if the first port is used for ventilating your patient, do not close off the second port. What you can do is, if the patient needs gastric suctioning, you can place, right, your adapter here, and then what you can employ is you could utilize NG or OG tube in order to suction. How would you size this? Ideally, the way you would, they state in the book, is from the mouth or the nose around the earlobe to the xiphoid process, but because we have a tube which is longer, right, than your nose and the mouth, so you want to size it from the tube around the ear to the xiphoid process. And then what you're going to do is you're going to utilize this as your suctioning device to decompress the stomach. So insert this up until the appropriate depth marking. You're going to connect this to your suction unit, and you're going to suction on the way out, decompressing the stomach contents. I would leave this in place so that the vomit doesn't go on you and you are protected. And you're going to ventilate through this port here. When you're done with this device and you have confirmed, you can secure it, right, with the Thomas tube holder, as you can secure it with all your devices that I have on my table, the supraglottic devices. Okay. Now I'm going to deflate it, and I'm going to show you the final one with the King Airway in place. So the King is essentially also a rescue airway, and unlike the Combi Tube, it only has one tube that you could ventilate through. Now you notice there's two types. There's King LTS-D and there's King LTD. So LTS-D has a suction in the back of it. So what is this suction used for? So the suction is used for to decompress the stomach contents, and you can suction through the back lumen here, and it will come out through this end. There's no oxygen that's being delivered through this opening here. If I connect my BVM and I ventilate and I connect my glove to the distal cuff, you notice it does not inflate. All your oxygen is coming through this inlet here. Okay, and the King LTD does not have the suction in the back. How much air are you going to place? So it tells you between 50 and 70 mLs of air. This for an adult is sized based on height. For the pediatric is sized based on weight. I'm going to go ahead and deflate my balloons prior to insertion. So the manufacturer recommends 50 to 70, and if you look at their manual, they'll include a 60 cc syringe, and they'll say actually put all of it in here, and it makes sense because it's between 50 and 70, and we have a 60 cc syringe, so it'll be right in the middle. How are you going to place this? So again, you're going to utilize a lubricant, and again, you don't want to lubricate the front end of it. The reason why, this is where oxygen is coming in, and again, you don't want aspiration. So just the tip and the posterior of the tube. I'm again going to perform a jaw lift like you saw with a Combi Tube and come in from the side. But unlike a Combi Tube where we placed it until the two demarcations markings, I'm going to put this in all the way up until the adapter is at the teeth. And then I'm going to inflate my cuffs, and I'm going to withdraw it while I ventilate to see optimal chest rise. So you'll say, why? What's the reasoning that you go all the way in and then inflate and pull back? And the reasoning for this, it's much easier to pull back. And then if you have air leak, to again put a few more cc's of air to close that air leak, as opposed to if you went too shallow, you then have to deflate your cuffs fully and then only then advance. So there's more steps if you put shallow. So it's faster if you go all the way in and pull back to see that. So we're going to put 60 cc's of air, jaw lift from the side, and I go all the way in until the adapter is at the teeth. I then not going to hold the tube in place because again I want to take it normal shape. I'm going to put 60 cc of air. And you notice again, it molded to the airway. I'm then going to connect my Untitled CO2 detector, which I have placed on the table, and my BVM. And you're not going to see an immediate chest rise, and I explained this because I'm going to slowly advance the tube upward until I see optimal chest rise. And you could feel it. You'll have ease of back compliance once you regain. So you notice once I regain chest rise, the compliance on my back improved drastically. I'm going to then listen if I have any air leaks. We'll only put 60 cc of air. If I had any air leaks, I will then again may correct that, putting maybe 5 or 10 more. And I'm going to verify my placement objectively with my Untitled CO2 and also auscultating lung sounds to see that I have presence of lung sounds in all fields. And once I'm fully confirmed, I'm going to utilize my Thomas tube holder to essentially secure it. Far too often I see this placed inappropriately. So how would you place this device? So if my partner is ventilating the patient, what you want to do is you want to position this mouthpiece aperture facing towards the feet always. Anyone who tells you it's supposed to be upside down so you could read Thomas, do not know what they're talking about. So tell them to watch my video and read manufacturer's guidelines. So then what I'm going to do is place this under the patient's head. This is called a V wedge because it resembles a V. I'm going to then insert my tube into the V wedge like so. Once it's in the V wedge, I'm not going to tighten my screw. I'm going to then position my bite block into the patient, making sure that the lips, right, are not caught when I'm doing that. I'm going to use my slider to assist me in securing my strap. Once it's in place, I can take this off. I no longer need it. And I'm going to secure my device. I first want to verify that my Velcro strap is securely on the patient. right? And I'm satisfied, only then and I'm going to go ahead and secure my screw bolt in place. The reason why is that I don't want to be moving it about when I'm doing this. You also want to be careful that you don't put it too tight to occlude the tube. This will prevent this from kinking if the patients were to start biting on the tube. So this is how you would employ all these three devices in order to secure the patient's airway